So go ahead and take it away, Halal.
Perfect. Thank you, Zach, for introducing. Hi, everyone. My name is Hilal. I am a junior at Princeton University studying molecular biology and global health and health policy. And today, like Zach said, I'll be sharing on my project Cuidando Juntos, Empowering Women's Health Through Cervical Cancer Prevention. And this project was carried out in collaboration with Partners for Indian Community Health, POCH, and Hospital Fibus in Ecuador. Sorry, one second. Okay, my bad. With support from Davis Prize for Peace and Princeton University. And the name Cuidando Juntos, or Caring Together, really reflects the heart of this project. This project wasn't just about delivering medical services, but about working hand in hand with communities, building trust, and ensuring women have access to care, information, and empowerment that they deserve. Um, so let's begin. So this initiative, like Zach said, has been a very long process. It builds on the work that I started during my 8-week internship the summer of 2024 with Potch and Hospital Fibusfem in Riobamba, Ecuador. And to give a little background, Hospital Fibusfem provides affordable healthcare to underserved populations, not only in Chimborazo, but also all across Ecuador, and collaborates with Potch for equipment, training, volunteering support, and more. And so during my first summer there, one of the main projects that I worked on was designing an intervention framework for a cervical cancer prevention, screening, and treatment program. And so part of that, I reviewed past initiatives, assessed like available supplies, conducted stakeholder and geographic analysis, and helped create an outreach strategy. And I also work closely with FIBUS-PIMS doctors to understand the major barriers that women face in accessing care, which was like it ranged from distance and cost to cultural barriers and limited awareness. And so that summer, although I had completed much of the groundwork, there was still a lot left to do, which included securing funding, refining the plan, and actually implementing this project. And that first summer, saying goodbye was really difficult because I really become a part of the Passion People Swim family, and I knew that I really wanted to return to bring this project to life. And so I applied for Prize for Peace, which is an initiative that provides Princeton undergraduates with a $10,000 award to design and implement innovative service projects that build peace and well-being anywhere around the world. And so after receiving that grant and with additional fundraising through Patch and FIBUSFAM, I was able to return this past summer to lead the implementation phase of the cervical cancer prevention program. And so throughout this presentation, I'll walk through how that plan became reality, what we implemented in the summer, what we learned, and how hopefully this program can continue sustainably in the years ahead. And so, oh, my bad, sorry. And so first, why cervical cancer? A little bit of background. Cervical cancer is a highly preventable disease, yet it remains as a significant global health issue. It's currently the fourth most commonly diagnosed cancer and cause of cancer-related death among women worldwide, but its impact is far from being evenly distributed around the world. As you can see on the maps, Latin America and parts of Africa carry a much higher burden compared to North America and Western Europe. And in Ecuador, cervical cancer remains the second most commonly diagnosed cancer and second leading cause of cancer death among women. Despite the establishment of a national HPV vaccination program, there are many barriers that still persist, which includes limited access to screening services, cultural stigma, lack of education, public awareness. And so these challenges are even greater for women in rural and indigenous communities. And so addressing cervical cancer in these regions became a key focus for my work, both the summer of 2024 and this past summer during this project's implementation phase. And so this map shows kind of the geographic scope of our project. The short-term goals focus on early detection and treatment of precancerous lesions, reducing the risk of advanced cervical cancer among an initial target of around 500 women across 6 provinces. Um, and the objective was to reduce barriers to screening and treatment by integrating mobile clinic caravans, culturally tailored education, as well as follow-up care. And a big part was also aiming to strengthen community trust by collaborating with local leaders, including parteras, which are midwives, and equipping them with the accurate information to continue outreach after the campaign. So, as part of this goal, the project was carried out really closely with Hospital Phoebus and Potch, but also with community health workers, municipal leaders, including mayors, to integrate their perspectives and ideas throughout the implementation. And this collaboration was key not only to ensure the project's success, but also making sure that it was truly supported by and in the hands of the communities that it was meant to serve. And this is something that I really valued because they're the ones who know what their specific needs are, what the specific perspectives that we need to know to create an effective project. And in the long term, this project seeks to help lower cervical cancer incidence and mortality in Ecuador, and to hopefully establish a permanent prevention program within FIBUSPAM's outreach network. And initially, the project was planned only for the Chimborazo province, where FIBUSPAM has longstanding partnerships. However, with additional fundraising support from POCH, we were able to expand to a lot of new regions, particularly Moreno Santiago and Napo in the Amazon, which really created a really wonderful opportunity to build relationships with communities that have almost no access to gynecological or specialist care, and where the nearest hospital is hours away. And so the campaign took place over 20 caravan days in 13 communities in 6 provinces. And on the right on the map, you guys can see which communities we worked with. And each location represented a unique cultural and logistical context. Um, and to achieve these goals, the project was structured into 3 main phases. So community education and engagement, screening and treatment, and follow-up care. And I'll go into how each phase was implemented as well as we continue. And in terms of timeline, this project followed a 20-week timeline that moved from preparation to implementation, follow-up, and evaluation. So the first 4 weeks, I was doing remote planning and coordination with FIBUSPAM and POCH. During that same period, David Guacho, who's the director of Hospital FIBUSPAM, and Magali Morocho, she's a nurse and was also really played a really big role with this project with me. And she also works at FIBUSPAM. They were on site meeting with local authorities and community leaders during these first 4 weeks. Week 5, we transitioned to pre-campaign activities, so that included staff orientation, volunteer training, and the production of educational material. And week 6 to 9 were the main mobile clinic phases when we carried out the screening and treatments across several provinces. And a second smaller campaign took place in Napo during week 13. Um, and we maintained continuity of care through both remote and in-person follow-ups between week 10 and 12. And the final part of the project focused on data collection, reflection, quality feedback, and compiling everything into a final report. And so the report also includes a detailed calendar listing all the locations that we traveled to and the specific campaign dates for each location. And so now going more into the implementation phases. The project followed a 3-phase model. And so the first phase included community education engagement. So this focused on building trust through collaboration with local leaders, implementing a structured community coordination process, which I'll get into. And this phase also included the sharing of the education material to promote awareness and understanding. The second phase, screening and treatment, included the mobile caravanas to deliver free, high-quality cervical cancer screening and treatment directly into communities, overcoming a significant barrier into healthcare access. And the services include visual inspection with acetic acid for screening and thermocoagulation for treating precancerous lesions. And finally, the third phase, follow-up care, ensured continuity of services through in-person visits and remote check-ins. And these follow-ups really allowed us to, monitor healing processes, provide post-treatment guidance, and also encourage continued engagement with healthcare providers for all of the patients. And so getting into first community education engagement, the first phase. So before I arrived, David Guacho, Magali Moracho led an extensive coordination process with communities. I wanted to kind of deep dive into this and explain this process because I think there's a lot of work that's done usually behind the scenes that a lot of us who contribute to these projects from the United States don't get to see a lot of times. And so I think bringing light to a lot of this work is also really important. And so the first process begins with identifying communities. Um, and so we began with identifying provinces and cantons that would most benefit from the project. And so that included looking at existing healthcare coverage, previous outreach efforts to ensure that the resources were directed to areas with the greatest unmet need. And once potential areas were identified, David met with mayors, provincial leaders to present the project's model of free comprehensive care that included screening, treatment, and follow-up. And many communities were initially cautious because some groups in the past might have promised them free services, but later charged fees or lacked qualified staff. And so trust was a key part of this project. And FEBUSPAM's strong record and its recognition and even its visible social media presence really helps establish credibility between communities. And also David's long history of, doing humanitarian work across Ecuador since 2012 was also a major factor in building trust. And during these meetings, David gathers key information. So, whether the region had recently received gynecological services, the level of healthcare access, if a canton already had gynecologists or similar services, we wanted to redirect the project's effort to areas with higher need. And once interest was confirmed, David worked with each canton to formalize the partnership through a convenio, which is a signed public agreement granting legal permission for the project to operate. And these agreements are essential because Ecuador's cantons are autonomous, meaning legal access is required for local authorization. And these agreements also mobilize local leaders to play a really big role in the project through helping recruit participants, arranging spaces, and also helping us with outreach, so spreading information through local channels like radio and community WhatsApp group chats. And once sites were confirmed, David personally inspected classrooms and community halls to ensure that they met the project's logistical requirements. And so this process typically followed three steps with the initial dialogue to assess interest, confirm no overlapping services, and understanding needs, two with agreement signing, and three with site inspection to verify adequate space. And after all these agreements were signed, we finalized caravan dates and locations. And when I arrived in Ecuador, I needed to ensure that both the medical and educational materials were ready for before starting implementation. And so on the clinical side, this included gathering all essential supplies for screening, things like gowns, gloves, diagnostic instruments. And so I calculated the quantity of consumable materials based on our target of around 500 women. But just as important as the medical side was the educational component. I really wanted women to feel informed, comfortable, and empowered to participate. And so during my first week, I worked with Dr. Ramirez, who's a gynecologist, and Dennis, a videographer, to create educational videos in both Spanish and Quechua, which is the indigenous language spoken in the Andes. And the foundation for these videos began during my 2024 internship when I wrote the initial transcript based on conversations with patients, healthcare professionals, and community leaders. And the goal was to design a resource that would speak to multiple audiences within the community, women, their families, also men. And so this summer, I refined the script, filmed new sections with Dr. Ramirez, and helped put together the final version. And the final video included several sections with an introduction to cervical cancer, the importance of screening, explanation of the VIA screening method and thermocoagulation treatment that we would be using in the campaigns, responses to common questions and misconceptions, and finally, testimonials and a call to action that featured not only women, but also men and community leaders who emphasize the collective importance of prevention and early detection. And after completing the Spanish version, we also worked on recording the audio in Quechua, which we use as a voiceover to create a Quechua version of the same video. And I also developed post-treatment instruction sheets for that, patients that did receive treatment through thermocoagulation. And both of these resources were really key in addressing barriers related to lack of access to education and also emotional barriers like fear and mistrust. And in addition to preparing the medical and educational materials, I also worked on a detailed budget planning for all the campaign phases. So this included calculating transportation, lodging, meals, material costs, as well as one-time equipment investments like the colposcope and thermocoagulator. And all these resources are documented in a Google Sheet that's part of my final report. And so it provides a comprehensive budget breakdown based on the screening of approximately 500 women and also the number of patients we provided in-person follow-up. And hopefully this budget can serve as a model for future campaigns as well. And on the next slide, I'll show some short clips from the video and also an example of the patient instruction sheet that we distributed. Um, okay, one second. So this is the video, the Spanish version. So.
Hola, soy el doctor Donald Ramírez, ginecólogo del Hospital FIUSPAN, y hoy vamos a hablar un poco de lo que es el cáncer cervicuterino y cómo prevenirlo. El cáncer cervicuterino es un cáncer que afecta el sistema genital de la mujer, en especial la parte del cervix, que es esta parte cónica que tenemos aquí. Conecta lo que es la vagina con el útero. ¿Sabes qué es lo?
So we first started with kind of introduction of what cervical cancer is, what HPV is. I'm going to skip around just because I don't know if we'll have time to watch the entire video, but then we kind of went into talking about what to expect in the screening process. So, oh, sorry, 1 second. What to expect in the
De
screening
FIBUSPAN
process.
es el método IVA. El método IVA significa inspección visual con ácido acético. Primero, se te va a pedir que te pongas una bata, te acuestes en la camilla de examen y te coloques en posición ginecológica. Posteriormente, el médico probablemente te va a pedir que separe las rodillas. El procedimiento.
And then we jump into kind of frequent questions and misconceptions that I had identified with my conversations with doctors and patients the summer before.
No tengo síntomas, doctor. ¿Es necesario poder realizarme esta prueba? ¿Por qué me lo tengo que hacer? Claro, por supuesto que es necesario. ¿Por qué es necesario? Porque puedes pasarte unos 10 a 15 años asintomática después de la infección con el virus del papiloma humano. Pero esto no te exenta a presentar lesiones precancerosas en un futuro. Por lo tanto, te recomiendo que te realices tu prueba de detección.
And then we also included testimonies from community leaders.
La enfermedad es como un veneno, pues que están mejor atacando a las mujercitas.
Bueno, yo creo que es importante que todas las mujeres nos hagamos chequear, nos hagamos ver constantemente, ya que esto puede prevenir un cáncer en el futuro y obviamente esto también nos pueden ayudar a.
And also, lastly, kind of a call to action in the end.
El cáncer cervicuterino se puede prevenir con exámenes regulares. También, toma control de tu salud y la salud de tus seres queridos el día de hoy. Únete a nuestras caravanas para exámenes y tratamiento gratuito. Es un simple paso que puede salvar tu vida.
And so this is kind of just some snippets of the video, but if you'd like to watch the video, we have the complete version on Pacha's YouTube, as well as the version in Quechua. They're both uploaded on the YouTube. So yeah, I think this was definitely one part of the project that I was really, really happy about. I think kind of creating a video was something that I had planned the summer of 2024, and seeing it come to real life was really nice. And then also utilizing it, which I'll kind of talk about as well. And initially, phase one was designed to also include like in-person educational sessions, so using this video for educating women before the caravans. However, while kind of implementing the project, we realized that this wasn't very feasible, just considering that women had, to manage a lot of responsibilities, whether that was agricultural work or just family responsibilities or other things. And so attending an extra session wasn't really practical. So to address this, we adapted the plan by sharing this educational video with local leaders and community networks to help distribute them through WhatsApp and community meetings, and also incorporated on the screening day, which I will talk about. And this is an example of the post-treatment instruction sheet that I created for patients who receive thermocoagulation. It explains what to expect after treatment and includes also specific aftercare recommendations. Also lists kind of follow-up steps, which includes when to schedule a control visit, and also provides the hospital's contact number so that patients can reach out directly with any questions. And so phase two focused on the delivery of the mobile screening and treatment services directly in communities. So each day we began with site setup and organization. And upon arrival, our team unloaded supplies and we prepared 4 main zones, which included a registration desk, a gynecology consultation room, area for vital signs, waiting area, as well as a small pharmacy. And so volunteers were trained to take vital signs, which included blood pressure, height, weight, oxygen saturation. And I also trained 2 volunteers at the first site to assist the gynecologist throughout the remainder of the project. And so patients first checked in through the registration system. And after vitals were taken, they were moved to the waiting area where I integrated the educational component from phase one. And so I use a projector to play the cervical cancer educational video that we just looked at before each consultation. So I really want to ensure that every patient understood what the screening involved, what to expect, and also why early detection matters. And this also allowed me to answer questions before they met the doctor. And so each patient was examined by the gynecologist who performed visual inspection with acetic acid, followed by thermocoagulation treatments if precancerous lesions were detected and could be treated. And originally, the plan also included biopsies, but due to limited capacity for safe sample storage and also just ethical concerns around maybe not being able to guarantee more extensive treatment for free, like surgical follow-up, we decided to remove this step. And while that was a difficult decision, it allowed us to expand our reach, allowing for screening and treatment for a greater number of women within the same budget. And after screening and treatment, patients received the post-treatment instruction sheets, and we also carefully documented patient contact information for those who underwent thermocoagulation to ensure follow-up tracking. And at the end of each campaign day, all medical outcomes were transferred into a Google Sheet record of 500 patients, which included their ID, vital signs, diagnosis procedure, and also medication that was prescribed to them. And so I want to share some pictures from our location. Okay. So this is from Polora, which was our first site actually. And so here, the second picture, you can see this is our little pharmacy. Here we have our two wonderful IFE interns who help with the vital signs. Down here, this is kind of like the waiting area that we had, and here we kind of projected the video for everyone to watch before heading into consultation with the doctor. And this is the changing area as well as the gynecological consultation area and the materials that the gynecologist and the assistant used. And then here I have some more photos. And I just wanted to kind of talk about how each community we visited looked really different, from the size of the spaces to the resources available. And so part of our work was adapting to whatever environment we arrived in. In some locations like Loja, we were able to use community halls that already had good lighting and electricity. But in many of the smaller or more remote locations, the setup looked very different. In some places, we even had to arrive the day before to prepare the place and make sure everything was ready for the next morning's caravan. And so these photos show a few examples of that and how we transferred classrooms, meeting halls, and even outdoor areas to functioning mobile clinics. And I want to also show a particular example from Latacunga. And so this short video is from Latacunga, one of the more challenging sites that we worked in. When we arrived, there was no private rooms, and just like an open space. And so as a team, we decided to create a makeshift consultation room using tarps and ropes, hanging them wall to wall. And it wasn't ideal, but it worked. And I think that really captured the spirit of this project. Every site we arrived to, it came with its own logistical challenges, but as a team, we were really able to adapt quickly and creatively. And so I think this video really kind of represents that. Going into screening and treatment outcomes and also diagnosis trends. So in total, we screened 500 women across 13 communities. Of those, 211, so about 42% tested positive for cervical abnormalities. And this is a notably high rate compared with national averages and really highlights the importance of continuing programs like this that bring preventive screening directly into communities. And also the rates varied quite a bit between regions. So on the right, there's a table that I created in my final report. And so, for example, Sukua, Wamboy, and Kacha showed the highest positivity levels, which could either reflect a greater underlying burden of cervical abnormalities or, in some cases, higher participation among women in these areas. Meanwhile, Baños, Kota, and Latacunga had lower positivity rates. And so I think doing this type of analysis will hopefully help us understand where risk and need are more concentrated and where to focus future efforts. And among those who tested positive, 174 women, so over 82%, received the same day thermocoagulation treatment. However, 37 women could not be treated immediately, and most of these cases required biopsy of the lesion before treatment, and also a small number of patients declined the procedure. And so when I analyze these numbers, I also look closely at locations while looking at the reasons for non-treatment, because I think this kind of data will also help us identify where follow-up efforts or additional education could strengthen future interventions. And finally, about 34 women were identified as needing additional surgical interventions, mostly for vaginal wall prolapse repair, which we had 23 cases of across all the sites, and with smaller numbers requiring hysterectomies and polypectomy. And the majority of these cases came from Morono Santiago, especially Palora and Wamboya. And we really want to note these numbers down because in the case that it can point to potential opportunities for future surgical outreach or specialized campaigns in regions that have high need but limited access to gynecological surgery. And overall, these findings really show both the effectiveness of a mobile community-based model and also the depth of the unmet need among the women that we reach. And I think really emphasizes why continuing and expanding this kind of work is really essential. And phase 3 of the project focused on ensuring continuity of care. So making sure that women who received treatment were followed up and supported during their recovery. Because the project targeted 500 women across 13 communities, it wasn't feasible given budget limitations to conduct in-person follow-ups for every location. So we prioritized regions without access to gynecologists or specialists where patients would otherwise not be able to receive post-treatment care. So we conducted in-person follow-up in Palota, Wamboy, and Sukua, three communities that are located in the Amazonian region where healthcare access is especially limited. And so screening in these areas took place in mid-June, and we returned about 4 weeks later to assess healing outcomes at the same sites that we had the initial screening. And during these follow-ups, each patient underwent a pelvic examination with the gynecologist, who also documented the healing outcomes for every woman. And what we found in these in-person visits was that in Palota, 20 out of 29 women returned for follow-up. And of these, 15 of the women were fully healed and 5 were still healing, but doing really well. In Huamboya, 15 of 26 women returned for follow-up. 9 were fully healed and 6 required 1 more week for full recovery. And in Sukua, 18 of 27 women came for follow-up. 8 were fully healed and 10 needed about 1 more week of healing. But most importantly, none of the women showed any signs of infection or post-treatment complications, which was a really huge relief and really rewarding to see. And we also had a much higher turnout than expected at these follow-up visits. Initially, the hospital director was concerned that patients might only return if something was wrong, and that follow-up visits might not be really effective. But I really want to push to include this phase as part of this pilot implementation. And the results show that women do come back when we return to their communities. And for the remaining communities, I conducted remote follow-ups by phone or WhatsApp 2 weeks after treatment for all patients who received treatment. And so during these calls, I asked patients about their recovery, any symptoms they experienced, and whether they had scheduled or planned to schedule a follow-up with a gynecologist. And all these responses were also logged in to a Google Sheet, which is also in the final report. And patients from the Chimborazo region were also invited to come directly to Hospital Fibuspan for their follow-up, since these areas had transportation to Riobamba by bus. And due to budget constraints, we couldn't cover the cost of follow-up visits for everyone who returned to the hospital. However, recognizing that cost is a major barrier, I coordinated with the hospital director to create a discounted consultation fee. So any women who participated in the care events were able to access follow-up consultation at half of the normal cost, so $15 instead of $30 at Hospital Phoebus Fam. So yeah. And so key outcomes and impact. Overall, these results, I think, reflect both the reach and impact of this project. In total, we screened 500 women across 13 communities, many of whom had never received a cervical cancer screening before. Alongside medical services, we also delivered 20 educational sessions across multiple sites. And this was really key to building trust and empowering women to take charge of their health. Of the 42% of these women, 42% tested positive for cervical abnormalities, which is, like I said, notably high compared to national averages, and reinforces kind of the need of expanding screening access in these areas, especially for women in rural and Amazonian regions. And among those who screened positive, 82.5% received same-day treatment through thermocoagulation. And this immediate treatment model is one of the strongest, I think, aspects of this project because it reduces loss to follow-up and ensures women don't have to make another trip to a hospital to get treatment. And through the screenings, we also identified 34 women who needed surgical procedures. And this data can now be used by FIBUSPAM to plan future specialized surgical caravans in high-need areas, particularly in the Morono Santiago province. And in the Amazonian region, where we conducted follow-up visits, we achieved around 67% follow-up rate, which was really high. And this shows, I think, that when care is accessible, patients are genuinely motivated to return for continued follow-up, even if they're feeling well. And I think most importantly, we recorded 0 post-treatment infections, which really demonstrates the safety and quality of the procedures and the post-care instructions. And so together, I think these numbers really speak to not only the effectiveness and sustainability of the campaign model, but shows that a mobile community center approach can both deliver immediate impact and also strengthen long-term healthcare access for women. And while these numbers show the measurable success of the project, I think what impacted me most were the stories from the women and the leaders that I met. Hearing their words and about their experiences really gave me a deeper understanding of the everyday barriers that a lot of women face in Ecuador. And not just this didn't include just lack of access to doctors or medication, but also the absence of trust, education, or autonomy. And these testimonies reminded me that beyond data, that healthcare is also about justice and dignity. And so this project, as part of Products for Peace, pushed me to think more about how I define peace. I think peace is not merely the absence of conflict, but also the presence of equity, justice, and opportunity, which includes the ability for people to lead healthy lives. And I think building peace can seem complicated, but at its core, it's about communication and empathy, which I think can be really simple. And so this project really, I think, built peace by bridging gaps between Western and traditional medicine through listening, dialogue, and collaboration, and not imposing solutions, but co-creating them with the communities that we were trying to serve. And I think by understanding where mistrust in healthcare originates, inviting open conversation, this project really helped restore that trust, which I think is the foundation for both health equity and also lasting peace. And I think one of the most meaningful parts was seeing how this project helped women reclaim ownership of their health. I think in many of these communities, lack of education and access strips women of agency of their own bodies, which I think in itself is a form of obstetric violence. And so through education and access to screening and treatment, women were empowered to make informed choices. And I think that empowerment and them being able to reclaim one's own health, what to me was an act of peace. And lastly, recommendations and next steps. First, from a sustainability standpoint, during my time in Ecuador, I also conducted IRB-approved research, which included interviews and surveys across the 6 provinces to understand the specific barriers faced by women in these regions. So hopefully, that's still in the process, but hopefully after I'm done analyzing this data, this will also be key to tailoring future interventions and improving the project, of what we need to focus on maybe in specific regions. Also, I think Princeton University's longstanding relation with POCH and FUBISPAM, along with the PILA program, the Princeton Latin America Fellowship, I think really ensures a path for future interns to continue this work. I think each new student can really build on the foundation that's been created through this pilot implementation of the project and keep it going, hopefully, for years to come. And to expand reach and stability, I think it'd be really good to formalize more convenios or agreements at the canton level, because currently, last I spoke with David, we have an agreement with Palora, but I think hopefully formalizing those agreements with other regions as well will expand reach. And I think it would be also really important to create, hopefully, a permanent cervical cancer prevention department within FUBISPAM. I think at the same time, it'll also be really essential to secure consistent funding to support the continuation and expansion of the program. And from a community and education perspective, while implementing the project in the Napo province, we partnered with parteras, so midwives, in an educational exchange. They were really enthusiastic to share their practices with us, and also they learned about the screening and treatment methods that we use in this project, so that they can kind of continue the education and outreach even after we left and inform more women who may want to participate in future campaigns. And so I think formalizing more educational exchanges like this across other provinces could really ensure that information continues to be circulated even after we leave these sites. And also, I think it would be really great to create a version of the education video in Amazonian Quechua, or Shuar, since some women in the Amazon understood the Indian dialect and the Spanish video, but I think they also noted differences in certain expressions. So I think doing that next step could be really nice for this project. And I think after my conversation with one of the community leaders in Palora, they recommended that a really nice next step would be to partner with schools and educators to integrate discussions about cervical cancer and HPV prevention into the caravan visits. And in terms of program improvements, I think as I said, the data showed that patients are really willing to return for in-person follow-ups when given the opportunity. So I think a really big goal would be to make all follow-up care in person and completely free. And if returning to every community is not feasible, I think a priority should be to secure funding for free follow-up consultation at Hospital FEWSFAM for patients who participate in the caravan and who live close enough to travel to the hospital. And like I said, we identified 34 women who require surgical interventions. So I think a key next step would be to secure resources to a possible surgical campaign. And finally, I think it's crucial to continue conducting monitoring and assessment using SWOT analysis, patient outcome data, and the qualitative tools I've used to getting feedback from some leaders and patients, which are all detailed in my final report. And so, yeah, I think all of these steps together can create hopefully a roadmap for a sustainable and community-driven program that can continue to grow year after year. And so thank you to everyone. So first and foremost, I really want to thank Potch, especially Zach and Sarah, for their guidance, mentorship, and constant support throughout the project's design and implementation. And I also want to thank the Potch IIP intern team who helped a lot during the caravans with taking vitals and assisting the gynecologists and helping with logistics and patient coordination. And from Hospital FEWSFAM, I really want to thank David, Magali, and Dr. Ramirez. They were there with me every step of the way, every caravan, and I think their commitment, also teamwork, really made this project what it became. And I'm also really grateful to the community leaders, parteras, and local authorities who welcomed us with such warmth and helped ensure that women could access these services in our project safely and with trust. And also thank you to Princeton University, the Prize for Peace program, and everyone who supports the ongoing partnership between FEWSFAM and Podge, as well as Princeton, allowing students to continue building on this work. And finally, to all my mentors and advisors, both those who are here today and those who couldn't join, including Mariella, Matt, Sebastian, Paloma, and Professor Sharkey, thank you all for your invaluable advice, your encouragement, and also support at every stage of this journey. So yeah.
Thank you, Hilal. And I'd like to make a short interruption before we continue with some participation from the crowd here. But I would really like to point out the significant contributions of Dr. Marty Bornstein and Shelby Shapiro through their foundation, Jean Axelrod Memorial Foundation, as well as our founder, Paul Martell. Without them, this would not be possible. Without all of these people that are present here, this wouldn't be possible. So thank you all.
Thank you.
But please, I'd like to, if anybody would like to share, please open up, unmute yourself. But from my point of view, this was an amazing experience. And it was so amazing to see so many different entities come together, entities and individuals. And it was just such an amazing experience to be down there. It's too bad it had to end, but we will work our hardest to keep this work perpetuating throughout the future. So thank you as well.
Thank you.
Hello,
Thank you, Sarah.
Marty here, and I'm sorry I have the crappy Wi-Fi. I have blown away again. You know, we talk about you often, and I'm so thrilled about this. And what kind of money are you looking at in terms of the surgical follow-up for the 34 people that need it, women that need it? And what kind of funding requirements to do certain things? Do you have any ideas on with regard to that for some of the programs you want to institute?
In terms of the surgical interventions, I don't have the exact numbers, but I think Sarah and Zach and hopefully David can also probably speak to that a little bit more of how much that would cost. In terms of the project itself, this project included a 20K budget for the 500 patients, but also in my final report, which I think Zach, if anyone would like to see, I think he can give access. It includes kind of a budget breakdown. But that was our budget. But I think Sarah, David, and Zach can also speak a little bit more in terms of what funding would be needed. But that's from the top of my head, some numbers. But thank you so much, Marty,
Oh, that's
for
great.
also and all of your kind words.
In terms of not being able to do the biopsies, and opting to treat more women,
Mhm.
what would it have taken to be able to do the biopsies and treat the same number of people? And I'm posing that to Zach and yeah, what's her name? Sorry. It's
It's
been a
okay,
rough
Marge.
day. You know who I mean.
Yeah, I do. So I think just a couple of things to start with. Halal, thinking about the 500 women that we treated through this project. And, we hope to have one more caravana this year on the coast doing the same thing, adding probably another 100 women. As someone who is in their early 20s and with the positivity rate of, I think, 46% it was, you saved the lives of 230 women already. That's really cool. And I just want to congratulate you on that because some people live a whole lifetime and can't say that, but your contributions to humanity and to these women already is huge. And I say this all the time to you, Halal, but I can't imagine what you're going to do when you're 40, you know? Like, it's just exponential. Like, this is so exciting. Um,
Yeah.
but Marty, to answer your question about sampling and biopsies, the challenge is around logistics and sort of keeping those biopsies in a state where we would have accurate results until we get back to the hospital. And working in the Amazon and in some places that are very humid, very hot, and then other places like the Andes that are very cold, we need to really think deeply about the logistics and ensuring the integrity of those samples. I think that we could improve by perhaps requiring biopsies for cases that are more advanced. Um, but that's something to think about how we could do that if we really wanted to turn this into a gold standard test. Um, in regards to the surgery for the 36 women who need it, we're hoping to plan a surgical caravana in 2026. We don't have a budget for that yet, but we're working on it as part of our planning for next year. But I'll pause there in case anyone has any other questions.
And I'll just interject as well, to address a few other things. Like we have several members on our team that are now in the receiving, the report from Halal, and also a lot of other research that other interns did over the summer. So we have an entire team that, and Sarah, myself, and several other members of our team that are doing a deep dive, not only into what we did statistics wise, and to find out information about our treatment and our procedures and everything, but also we will be diving into this extensive report that Hilal has prepared, which also details specifics on how to continue this into the future with very a lot of details on the numbers and practices. Um, so that will be coming out soon. I see Shelby has his hand up. Yep.
Just to let you know, we shared your last video with another member of our board who is involved with the Plateau State in Nigeria. And we said to her, in trying to do some of the same things, and we said, here's a good model for you. And we will be sharing the video of this talk with Diane as well. She was blown away.
Thank you.
And I continue to be totally blown away. So thank you, thank you, thank you.
Thank you so much. That's really wonderful. I think a big goal of this project was that it hopefully can be a replicable model for other underserved regions across the world. And so I think Nigeria is definitely that is really wonderful, and I'd love to also hear about if they want to implement or if they want to get into contact with. Speaking about the project, I'd also love to kind of talk with your contact as well. So thank you for sharing.
Yeah,
Solid.
definitely, definitely. This project is working with some of the women who were kidnapped from Boko Haram, and
Hmm.
they are establishing healthcare. And so I don't know enough about it yet, but Diane definitely does. So you will be hearing from someone, as will other members of the team and the like, because we're just I am speechless. I'm speechless.
Thank
I
you.
need to say anything more.
Thank you so much.
Paul, please. Paul next.
Yeah,
Yeah.
real quick, I just want to congratulate you, Hilal, on a great accomplishment, a profound accomplishment. You did a great job, and your report is very comprehensive and interesting, well put together, and you've done a great job. So congratulations to you and to Zach and to everybody involved, really. Um, um, it's been a pleasure to support you in this, and I hope to be able to do that in the future. So a couple of very specific questions, though, if you don't mind, because I was involved in this years ago in this particular field, and I'm interested to know. You mentioned that there was a stigma about an HPV vaccine, and that rung a bell with me. And I wondered if you could talk about that a little bit. And I have to tell you, for all the years that I've been going to Ecuador, I have heard that they have an HPV vaccine, but I have yet to meet anybody that has it. So that's a whole mystery to me, that whole field. But what was the stigma? Is it the husbands that didn't want them to get it, or
In terms
what
of
is it?
the HPV vaccine itself,
Yeah. Why would there be a stigma about a vaccine?
I think I can also I don't know if Amelia's still here, but we're actually working. She's working on a HPV vaccination program project that's kind of like continuous of this project. My kind of questions and interviews were with women were more on like cervical cancer screening, but I do think a lot of barriers with that would probably overlap with HPV vaccination. I think firstly, like lack of awareness. I don't think a lot of people are also aware that this vaccine is available in health centers. And I think a lot of it happens through distribution in schools. And so there's also a lot of aspects of that with, for example, if, children are missing school days or if they're not at school during the vaccination campaign, are they missing out from being vaccinated? And are they informed of how to get the vaccine afterwards? I think another aspect is probably also mistrust in Western medicine vaccines in
Yeah.
general. And I think also the topic of cervical cancer and HPV also has stigma just because of the topic. Um, because I think a lot of times the reason why HPV vaccine is really effective is that usually girls and boys will get vaccinated before any kind of getting into any kind of sexual relations. And so like the importance is that like you get vaccinated before anything so that the vaccine can protect you from the virus. But I
Right.
think a common not only in Ecuador but even across many countries around the world is that like oh, if my child is not engaging in this, they shouldn't be getting the vaccine. So I think it's also a lot of misinformation. But that's definitely something that's very important, I think, in terms of prevention of cervical cancer. And actually, one of my Professor Sharkey from Princeton, she had found an opportunity of a learning series and a project proposal for HPV, bringing up HPV vaccination rates in any country that you propose. And we applied to that project through Potch and Phoebe Spam. And currently, one of the PL fellows, so Amelia, she's also on this call. Maybe if she wants to say something, is working hopefully on, has been going through those learning series, but working on hopefully putting together a project proposal related to also HPV vaccination. Um, and I think that will also really complement this project as well. But like you said, Paul, I think it's definitely really important because it's a big prevention aspect of cervical
Yeah.
cancer.
And I've never understood why, for example, Spam cannot give those vaccines. But my understanding is it's very highly restricted. Only certain institutions can give the vaccines. It's ridiculous. I mean, we're
Yeah,
there. Why can't we do that?
yeah.
I don't know. It's puzzling to me.
Yeah. I don't know if Amelia, if you want to jump in. I have
Yeah.
like a quick answer in my head, but if you want to say something too, for sure.
So, to give you all a little bit of context, since 2014, the Ministry of Public Health has been providing free HPV vaccines to anybody in a specific age range who needs it. So, it used to be girls 9 to 11 years old, and they have school-wide vaccine campaigns that go once or twice a year to every school, private and public. So, Ecuador actually does have one of the highest HPV vaccination rates in Latin America. It's around 85 to 90%. However, it's lower based on what we've been able to suss out via interviews with doctors, school administrators. It's lower in indigenous communities because there's more mistrust in vaccines. And um, really, how it works is parents find out 2 days beforehand that there's going to be an HPV or there's going to be a vaccine brigade at the school. They're given an authorization form that just says the types of vaccines, and then they authorize or they don't authorize. So every girl, and now this year they've added boys who are 9 years old specifically, do have the chance to get the vaccine, but it's not paired with any comprehensive education campaign. And so that's what we're thinking about developing. These past weeks have done around 15 interviews with parents about their perspectives on the vaccine and what they know. And basically, what I've gotten from those conversations is that parents have either heard HPV, but they don't know what it is, what it can cause, that it can cause cancer, or they've never heard of it to begin with. So we're really trying to address that and thinking about how to use behavioral science to increase uptake. And then the reason FIBUSPAM itself does not give the HPV vaccine is because it would cost around $200 per vaccine, whereas via the Ministry of Public Health, it's free because they have an agreement with the Pan American Health Organization to buy it at low costs.
Yeah, since FIBUSPAM is a private institution, the vaccines that come through PAHO don't, I think, only go to public institutions. And so I had spoken to Olga about this, but she said the vaccine, it's also like 2 doses, so it'd be like around $200 per dose. So that's, I think, definitely
Wow.
economic constraints for FIBUSPAM not being able to give the vaccine, unfortunately.
Okay, that's super helpful. I had one other follow-up question, just real quick. 19% non-consents to have the lesions treated. Why?
Yeah.
What was the reason that was given there?
I think there's definitely a range of reasons. I think fear is still a really big barrier among women, because I think, I mean, the point of, creating the educational video was hopefully to kind of address those barriers of fear and mistrust. But I think sometimes I think women still might have continuous fear. Other times, also some women so that they need to ask their husbands, and that also creates another barrier. So
Yep.
it was definitely a smaller number of patients, but there were still some barriers of that. And I also like have numbers of um, how many patients in what region, which site said no, and the reason why, whether it was biopsy need or whether it was like not wanting to consent to the procedure, so that
Right.
like hopefully in the future that can also kind of um, like improve our efforts of intervention. Maybe we have to, put more effort into education in Palota because more women said no because of just not wanting to consent to treatment.
Right.
So yeah,
It's very challenging.
yeah.
Okay, good job. Thank you.
Thank you, Paul.
Hello. I have to echo, obviously, all of our congratulations and just all of the hard work that you've put into this and everyone on this call. I mean, I think it's pretty evident that community and, being invested in the communities that are represented here matter. Which sort of leads me into a question maybe you have some more insight on, kind of addressing that fear and some of the barriers of receiving follow-up care. Are there thoughts or have you discussed community support services specifically for those who are, receiving positive test results, thinking about mental health support and other community support services that might be able to kind of create more conversation around follow-up care and, being consistent and having a little bit more ownership on self-care as well. I don't know if that's something that you've thought about or are in conversation with different organizations about, or has been in conversation at FIBUSPAM or with the care within the caravans themselves.
Thank you, Mariel, firstly, for joining and being really supportive. I think definitely like the other aspects, I think on top of physical health, like mental health is really important too. And that's not something that I worked on with this project, but I think that's something that definitely hopefully the next intern or next PL fellow or someone, it would definitely something that I think should be focused on, like you said, because all of these are very overlapping, right? Like mental health and trust and everything. It has such a key role in women wanting to, take part in these services of screening and treatment and follow-up. Um, I think in terms of kind of having more of the community participation, like I said, in the Napo province, in one of the community sites, we partnered with midwives who kind of serve the community and helped, we watched a video together with them and talked about their practices that they also use and also what we do with the screening and treatment so that they can also do community education even after we leave, so that in the future, hopefully when we have another campaign there, there'll be more women who want to partake. So I think those kind of building more of those relationships is really important to, because I think that also builds a lot of trust when it comes from someone who's from your own community, who's a community health leader, and you've interacted throughout your like life living there. And so I think that's one aspect. Another aspect of I think strengthening follow-up beyond even just like the initial follow-up, I think anyone who got follow-up with through us or even through like other services or other gynecologists, they're recommended to, for example, get a pap smear every year following this kind of service. And um, while also serving a lot of the patients from my IRB study, like a lot of patients had not received a pap smear until, maybe this was their first time getting screened or had never received a pap smear, maybe once in their life. And so obviously that continuity of care is also really important. And it can become really complex and difficult, I think, trying to do it from one location across all provinces. But I think that's where the community partnerships really comes into play. For example, in Palora, after we went for follow-up, to do the first, pelvic exam after 3, 4 weeks after getting the treatment. We also the community leader who we worked with helped arrange one of the doctors from the health centers there to also attend our campaign. And so that doctor, she also got a list of the patients who had treatments and got follow-up so that they can follow up with them to make sure that they got a pap smear 1 year later. And so I think for like care doesn't end in that one treatment and one follow-up, it's continuous throughout your entire life. And so I think building more of those relationships would also be really, really vital. So I think having, for example, that doctor from the health center be with us that day and see those patients, interact with them, and have their names and contact information for future follow-up was really important. So those are the things that we've kind of discussed so far, but I think the mental health aspect that you brought up, something really important that we can definitely work on. But yeah, I don't know if anyone from Podge, Amelia or Zach, if you guys have
Zach,
any.
you let me know what sort of students you need, or if you're recruiting in that area. I'm happy to work with our Princeton students and see where those needs can be met.
Yeah, it sounds good, Mariela. And, just on that topic, it was, so amazing to have our, interns team supporting this as well. And just to inform our, the people who are listening, this was such an amazing experience to have an intern team, our Potch team leadership, Hilal, and then our amazing Fibu Spam team in person, all putting this into action. Like Hilal said earlier, with like talking about our executive director David Wacho and that team at Fibu Spam, they were just so amazing when we were on the ground down there. And now we have our Pila fellows that are following everything up with us. So this is a really amazing group of contributors that we have, from the people that are putting things into action and planning to our support network that we have, including Dr. Marty and Shelby and our founder, Paul Martel. This has been so inspirational, and I cannot wait to share with you all of the information and the notes that I'm still getting from interns from this past summer, who they want to thank us. They also want to share their ideas with us, and they also want to collaborate again in the future with us. So it's just so amazing to see. And thank you, Mariella, especially for all the time that you've dedicated to the interns, all self-planning over the past year. As we're still talking practically every other day online.
Yeah. Who knew Mariella from freshman year to now? This is where it would go.
I kind of saw it coming. No,
Mariella, are you at Princeton? I'm not familiar with you.
yes,
This is
yeah. So
Marty.
I'm one of the assistant directors for the international internship program. So part of our work is
Wonderful.
to get the interns on the ground and really work to understand the needs of the organization and find the right people. And I think, when Hilal and I met her first year at Princeton, she had a lot of ideas, and I knew that the Potch team would just be the perfect space for them, and it shows. And I'm just, it's always so inspiring to hear it come from the students and to know that you are always going to have the support of our teams, many others who are represented from Princeton in this room to make things like this work. So thinking about the next group of interns and knowing that you're still wanting to collaborate with the students who've been there before, we try to find the best ways to make that happen and make it work, and find the funding to make that possible too.
Thanks to Mariella she puts in so much effort to making sure that she pre-vets the right group, the right students to send to me. And yeah, we've had some amazing students recently, and looking forward to the future. If anybody else has,
Thank you.
please chime in. But thank you for attending today. Thank you, Hilal. Thank you, Paul and Marty, Mariella, Amelia, who is continuing our work into the future along with our team. Shelby and Paloma, thank you, and thanks just to everybody. It's been like I keep on repeating myself. It's been so awesome. I will be sending this video out to everybody along with a comprehensive review of just what has been going on during this summer and then moving into the future. And we look forward to seeing everybody again soon somehow.
Great. Nice work, everybody.
Thank you so much for joining again. Thank you.